Thank you to everyone for joining MDA today as we host our Grand Rounds webinar, Newborn Screening in the U.S., Working with What We've Got. And I'm excited to hand off our webinar to Dr. Caitlin Batley to begin the webinar.
Hello, nice to see you all today. I'm Caitlin Batley. I'm a pediatric neuromuscular neurologist, and I work at UT Southwestern Medical Center in Dallas, Texas. And I'm very happy to be joined today by Dr. Steve Krzyzanowski and Dr. Craig Zaidman, who will be talking a little bit after me. So next slide. So today we're hoping to review all of the neuromuscular conditions that are included currently on the newborn screening list. This can vary based on the national recommendations and then what's locally implemented. And so we'll be talking a little bit about how these disorders get chosen and kind of a little more about that process. We will talk about ways that we are able to detect and then furthermore confirm these diagnoses and follow-up, and then ways that we can communicate the newborn screening testing, how we can get to see different specialists, and really provide that kind of seamless continuity of care. Next slide. So today we'll go over the background of newborn screening. We'll talk about some things that we've learned from already well-established programs, and then move on to the preparation in place for screening for Duchenne muscular dystrophy, which is one of the conditions that we're talking about a lot these days. And then looking forward to what this means for our clinics, what this means for our families, and where we can expect to go from here. Next slide. All right, so next we will talk a little bit about newborn screening, the rationale for this program, and availability. Next slide. So whenever we are determining whether or not a condition should be added to the newborn screen, there are several kind of criteria that really need to be considered. One is that it's a condition where lack of treatment or not having the diagnosis would lead to either significant disease-related symptoms or even death, usually as a young child. And so we know that these conditions are severe. There needs to be an effective treatment that is available and that has been proven to lead to better outcomes. And you'll see here, since we're going to be focusing on DMD, some of the examples are related to Duchenne. And so you'll see a list of different medications for Duchenne here. And I will say, we'll talk about this a little bit more in a bit, but there is still a little bit of uncertainty on the timing to utilize these medications and how that relates to newborn screen. And then, of course, there needs to be some kind of effective and reliable screening procedure that's widely available, that can be done in a variety of settings and situations, and that can be kind of implemented throughout the country so that we're providing equitable care, in every state and every city. And then, of course, there has to be a plan for follow-up. So getting the positive newborn screen is one thing, but then there needs to be a mechanism with which to connect patients who have a positive newborn screen to a physician who can counsel them on what this means, perform, the testing that's needed to either confirm or disprove this, and then the treatment afterwards. Next slide. So the three conditions that we'll be focusing on today are spinal muscular atrophy, Pompe disease, and Duchenne muscular dystrophy. And as you can see, this slide is just a lot of fun because this proves kind of how far we've come in neuromuscular diseases and the fact that there are numerous therapies available for each of these disorders is truly remarkable. And so one of the reasons why they're considered or already on newborn screening protocol is because we do have these therapies that can help improve outcomes. Next slide. So Newborn screening is a program that varies state to state. So we know that the U.S. Department of Health and Human Services recommends conditions to be included in the newborn screen panel. Um, and this is called the Recommended Uniform Screening Panel. And then each individual state uses this as a guide to help determine which conditions will be added to their programs. And so you can see here, we've got the map. They're both purple. The darker purple is the map indicating the state screening for spinal muscular atrophy. And you can see here that all 50 states are now screening for SMA, which is a huge achievement. And then you can see on the other map, these are the states that are screening for Pompe disease. And you can see here in purple are the ones that are screening, and in gray, the ones that are not. You'll see my home state of Texas is still gray, but we should be turning purple here any day now as we add Pompe to our newborn screen panel. But it is a process. Not only do, all of the people who make these decisions need to agree to add a test to a newborn screen, but there also has to be funding to support that program. And so that includes funding to actually, run the test, which can vary in expense depending on what kind of test is done. And then the funding for the personnel to follow up and ensure that these patients are getting managed appropriately. And so it can be quite a process. I know from Texas, for instance, we agreed to add Pompe disease to our newborn screen panel several years ago, and it's been a process to get it actually implemented. And so we're very excited for that, but it is something that takes time. Next slide. And so on a similar level, with Duchenne being discussed for potential newborn screening, this is not something that's yet been added to the RUSP, but there are several states who have made the decision on their own to go ahead and start screening. And so you can see here in the darkest green are the states that have approved and actually started screening. In the light green are the ones that are approved but haven't actually yet started the process. They're somewhere in the phase of determining how this will look in their state and kind of the logistics of that. And then in orange are the states that have kind of made strides towards beginning to potentially add newborn screening, but still waiting on some approvals from like a legislative perspective. I know for Texas, our governor has added this to our recommendations, and then we're just waiting on legislature approval to move forward. So this seems to be making some strides as well. Next slide. So there are, of course, just like anything else, there are benefits and challenges with everything. And so benefits, obviously, the goal of a screening program is to identify every single positive case or get as close to that as we can. And so with that comes the potential that there could be false positives. In our desire to not miss any patient, that does mean that there will be patients who have a positive newborn screen, and then they have to come in and do testing, which comes with anxiety, which can be meaning time off work, and so expenses for our families. So negative implications for families. And then they end up actually testing negative for the disorder and determining that they don't have it. And so obviously, I think a lot of people would be okay with going through that with the knowledge that it would be saving other children's lives, but it still can provide a lot of anxiety and stressors for families who do have to go through this and ultimately have a false positive. And so, of course, the other benefits is that it really does allow this early intervention for sometimes life-saving, otherwise life-changing care if we're able to even slow progression of disease or improve certain facets of the disease. Oftentimes earlier is better, especially with these kinds of conditions that are on the screening. But with that, of course, there are still several other challenges. We know that it can be very difficult to even just coordinate the care that's needed, especially when you're, calling from a clinic that the family doesn't really know and doesn't quite understand why you're calling them. It can be difficult sometimes to even get patients into clinic because these might be diseases that are ultra rare and they've never even heard of. We also don't have universal optimal screening methods that are used the same in each state. So some, use different kind of processes for doing this. We do know that sometimes we're flagging patients where the genetic testing might be somewhat unclear. We might have carrier status. We might have variants who are predicted to cause minimal or even no symptoms. And then, of course, with some of the screening processes, which you'll hear about in just a minute, there's also going to be some patients that are picked up kind of incidentally and might have other disorders, not the one we're directly screening for. And maybe this disorder doesn't have a treatment. And so now we're faced with giving a diagnosis to a family with no treatment available, and kind of the ethics of doing that. And then, of course, we still do need for some of these conditions earlier clinical trials that look at the way that these currently available or investigational therapies affect patients who are even younger, at the age that we're actually going to be picking them up on newborn screening if it's initiated. Next slide. All right, so now I will hand it over to Dr. Zaidman.
Hi, thank you so much. And hi, everybody. I'm Craig Zaidman. I'm a pediatric neuromuscular neurologist. I've spent almost 20 years taking care of boys and young men with Duchenne, Becker, and other related diseases, including Pompe and SMA. And thanks to the MDA for inviting me and putting this together. Next slide, please. Thanks. So Pompe disease and SMA, as you've heard, are already on most, if not all, of the U.S. state newborn screening. And I wanted to use this opportunity to discuss some similarities and differences in order to highlight the technical issues related to adding a new disorder like Duchenne to the newborn screen panel. So when you're testing babies for SMA, the test is actually a genetic-based test. It's not sequencing, but it's looking for copies of the SMN1 specific exon 7 in the SMN1 gene, and it can identify that. And if it's missing, then it flags it, and that would be associated with SMA. Pompe is totally different. In Pompe, the dried blood spot is tested to measure the enzyme activity of alpha glucosidase, or GAA. And if that enzyme activity is low, that triggers a secondary testing, including repeating the enzyme activity and looking for genetic testing. And that's a little more similar to the way Duchenne would work, where you're testing the creatine kinase, specifically the CKMM kinase. And if that is low, that triggers a series of additional steps in order to determine if it is in fact low, and then that would lead to genetic testing. There's pitfalls associated with all of these. None of them are perfect. The one pitfall for SMA is that there's another genetic way in which one can have SMA that would not be detected on this test. Not all states check for the SMN2 copy, which is a important additional gene to determine severity of disease. In Pompe disease, or the enzyme can be low, but you may not have Pompe disease, something called pseudo deficiency, and that has to be determined genetically. And in DMD, one of the potential pitfalls is that the level of CK that is chosen as the threshold or the cutoff for what's normal or abnormal actually varies with age and can include some false positives. You can also identify carriers that have high CK. In terms of the action that comes after a positive screen, that really is both state dependent and also disorder dependent. So in some states have SMA care centers where the newborn screen is sent specifically to a care center, whereas in other places, a positive newborn screen is just referred to a neuromuscular neurologist. For Pompe disease, there's quite a lot of repeat testing that needs to occur. At least in my state, newborns with positive screening are sent to a genetics department. And that genetics department performs the first round of additional testing to determine if, in fact, the patient has Pompe disease before they get referred to a clinic like mine. And in Duchenne, of course, it remains exactly to be seen what's going to happen for a positive disorder, but it will likely go either to a genetics clinic or a neuromuscular clinic in order to proceed with the additional testing required. The family communication, that depends on where you get referred and in what role your primary care doctor, your family practice or pediatrician plays. Some places, the newborn screen lab actually has a pathway for contacting the family directly, and in other states, the initial contact is through the primary care doctor, and sometimes primary care doctor plus the specialty clinic, either the geneticist or in this case, the neuromuscular clinic. Equity and access is, of course, very important. There are issues with communication, with multilingual requirements. Some families, it's just financially prohibitive to follow through with the repeated testing, and in other places, people can live very far away. And then when it comes to treatment, a lot of these treatments are quite expensive and they require prior authorization from insurance. Safeguards are an important part of the newborn screening pathway, especially when a new disorder is added, and they have to be tweaked. And each state or group of states does their testing slightly differently. So the algorithms can be changed, the cutoff thresholds can be changed, the data tracking to make sure that positive patients are being identified and referred appropriately and quickly. All of these things vary somewhat state by state. And then that creates opportunities for trying to improve policies. So standardizing referral pathways and standardizing treatment pathways to advise doctors like myself what to do with often what is a lot of new information. When a new test is added to the newborn screen, it creates a lot of new issues for us. So for instance, for Duchenne, what's the appropriate thing to do when you identify a carrier infant girl? How do we handle that? What do we do? That would be a new arena for us. Next slide, please. So let's use SMA as a sort of springboard for what we've learned. The methodology, it's not going to be the same methodology as for Duchenne, but it uses something called quantitative PCR testing, and there are actually thresholds for when you stop running the PCR. And if you keep running it forever and ever, it changes your detection rate. So at some point you stop running the PCR. You don't want to have false positives, but you also, of course, don't want to miss any. So we've had that experience, and so learning and tweaking the methodology will likely be part of the Duchenne pathway, as we'll hear more about in a minute. The safeguards include secondary testing. So if you have a positive dried blood spot, then we send additional testing to confirm that the SMN1 gene is deleted. And we would include SMN2 copy number testing. Some states include that as part of their first tier. And in my state, it's a second tier. And then having standardized referral pathways really helps ensure that positive patients don't get lost in the shuffle. And that's been a big part of adopting a neuromuscular clinic to SMA being added to the newborn screen. We have to get these referrals in quickly, as opposed to just putting them in line to be seen with everybody else. And the reason they have to be seen quickly is because time is nerve. And for SMA in particular, and for infantile onset Pompe, it's also true. The earlier you start the treatment, the better the outcome. So it's a really important and complicated pathway to go from a dried blood spot to getting the baby in front of you in clinic and getting the treatment initiated. Many steps have to happen. And that's one of the challenges with SMA. I'm often on the phone with these moms and dads, and they've often only just heard from their pediatrician, an hour before I call. So it's a very difficult emotional phone call, and to try to engage them, for them to trust you, having never met you before, and help them explain why they have to come see you right away is quite a heavy lift. And that's a challenge, and a pleasure to be able to play a role like that in some of these children's lives. And then each state is different. What's listed here is this pre-authorized care. I don't know of a US state that pre-authorizes care because the insurance system in the United States is so complicated. But in other countries, Italy comes to mind, there is a centralized care plan. And so positive infants have less hurdles in order to initiate treatment for SMA than they might face here in the United States. And then there are open questions, which tracking outcomes are very important. How many false positives were there once the patient gets to a doctor like me? And, we communicate back with the newborn screen lab about what the results were, whether it was a false positive. There are rare false negatives, and we work closely with our local newborn screen labs in our catchment area to try to improve pathways so we don't miss patients and we don't mislead patients. Next question. Next slide, please. Pompe disease has a lot of similarities with what I just discussed. The main difference being it's not a genetic test that's being performed. It's a measurement of an enzyme, the alpha glucosidase enzyme. And that gets into issues of thresholding, like we talked about with SMA, but it's a completely different methodology. How low of an enzyme level is too low? And what testing then is required? Typically, what's done is the level is repeated, and then genetic sequencing is also performed. That is the primary. Secondary testing, or the safeguard, is to sequence the gene that causes Pompe disease. And that's a critical step for Pompe disease because there are some children, some people who have low enzyme levels but do not develop Pompe disease, and we call that a pseudo deficiency. And there's some similarity to Duchenne here, in which you can have a high CK but be a carrier, or be minimally or mildly affected, or you could have a different disorder than Duchenne. And you may have no disorder at all. It may be that your CK level is high from another reason. So there's some rough similarities to Pompe here. And it's worth noting that the goal of the screening is to pick up the infantile onset Pompe patients, but most of what we detect is actually late onset Pompe. And those children don't necessarily need an urgent initiation of enzyme replacement. So that leads to quite a lot of additional conversation and monitoring for those children who may not develop symptoms of their disorder until adulthood. So that's quite an impact of the newborn screen process on those families. But ultimately, the goal is to initiate therapy early and pre-symptomatically, and that really makes a big difference for the infantile onset patients, and probably the late onset too, which we can really make an impact on their long-term survival. Next slide, please. So I mentioned that late onset patients as one of the challenges, and there will be some lessons learned when we start testing for Duchenne muscular dystrophy, because like I mentioned, we will pick up children with high CK from other causes. And we'll have to learn as a community how to best handle that. Pompe disease has that, but there is late onset Pompe disease. There are the pseudo deficiency alleles, which creates a lot of anxiety for the families, only to discover that they do not have the disorder. There are a lot of variations in the genetic sequencing where you can find a variant that it's not clear whether that person has or does not have the disease. And that leads to additional testing that's required, and that can generate a lot of anxiety while that's being done. And then, of course, in the United States, it's state to state pathways, depending on how the referral is done, whether it's centralized or not. And we are building protocols for how to handle these issues with Pompe disease, and enzyme testing in each state slightly different. And so that leaves, ongoing questions with Pompe disease. The biggest is, how do we standardize care of the late onset population so that we are providing adequate care for a disorder identified in an infant that may not present until adulthood? And how do we support these families in that process in a way that is fair and takes good care of the child without overburdening the family? Next slide, please.
And I'll take it over from here. My name's Steve Krasnowski. Thank you for the opportunity. I'm a assistant professor at the University of Massachusetts, and I run our pediatric neuromuscular program here. We're going to talk about Duchenne. As discussed previously, one of the requisites for newborn screening is treatments. And so I just lay that out here again, initially starting with steroids, leading to the flurry of antisense oligonucleotides, dissociative steroids, the microdystrophin gene replacement, and most recently an HDAC inhibitor. And you saw this map of states previously listed, and it's changing week by week on the legislation that's going through. As discussed, the recommended uniform screening panel is not recommending Duchenne at the national level yet, leaving this decision up to individual states, noting that challenges identifying the different cutoffs at different ages, whether newborn screening is actually going to have better outcomes, and the unclear benefits of early treatment. So you can see the catch-22 that we need the data, but we cannot get the data until newborn screening is implemented. Next slide, please. Ohio was the first state to launch newborn screening in April 2024 using the CKMM, creatine kinase, on dry blood spots, repeating testing if elevated and referring the persistently elevated cases for further diagnostic workup, followed by New York later the same year, using an adjusted model where they look at the age of the patient, how the birth was, if there's any trauma at birth. Again, repeating testing unless very high, and then referring to specialty care for genetic testing. Minnesota started earlier this year. Borderline results are repeated after 2 weeks, and persistently elevated cases move for diagnostic evaluation with genetics. So in summary, the first-tier testing is the same across different states, but cutoffs, repeat testing strategies, and the referral pathways do differ based on the local infrastructure and policy. Next slide, please. I'm going to use the study that we performed recently in Massachusetts as a point not to lead you one direction or another for Duchenne muscular dystrophy newborn screening, but just to lay some of the evidence on the opportunities, but also the challenges that we face. So we looked at over 17,000 male and female subjects in a two-step algorithm using a single dry blood spot sample, looking at the same CKMM, followed by, if necessary, targeted sequencing of the DMD gene. Unique to our study was that genetic testing was actually performed on the same dry blood spot that was collected for CK analysis. And the thought was that this mitigates and makes not necessary a repeated poke on the babies. This was important because it demonstrated feasibility of adding CK onto the existing newborn screening infrastructure, and such a model would potentially remove the barrier of who owns and is responsible for collecting repeat samples. We identified our cutoff to be at the 97th percentile, and this is a little bit different than what is being done in the other states, more inclusive, intentionally as to identify the lower limits needed to be as sensitive as possible. And our initial screen-in testing of CK removed 97.3% of study participants, for which next-gen sequencing was done on the remaining subjects on their already collected dry blood spot samples. Genetic testing was performed on 479 individuals. There were 6 whose initial dry blood spot samples were mishandled, and a CK was unable to be run, only genetic testing performed. The majority of those that underwent genetic testing were normal, had non-pathogenic VUSs with either normal repeat CK or family-deferred repeat CK. And we identified 5 pathogenic variants in the DMD gene, only females, which is really interesting, and we'll get into that. Next slide, please. Here's the raw scatter plot of the CK values that we collected between 24 to 48 hours of life. As you can see here, there's positive skew of the distribution. And we did it intentionally within this time period because that's what our state does newborn screening, between 24 to 48 hours, echoing the ability to piggyback off of our existing infrastructure. Next slide, please. Superimposed here are the CK values of our DMD carriers, and unfortunately, one of the females who was identified to be a carrier had one of those samples that was too old to be able to run a CK analysis on it, so was only sent for genetic testing and found to be positive. Next slide, please. And here we lay forth the 97th percentile in blue, our study, versus the 99.5 percentile, which was a commonly chosen number in some of the other studies. So what's important to note is that if we use ours versus the other states' thresholds, we would miss 3 individuals. The other states would miss 3 individuals that we otherwise picked up at. This raises discussions on specifically what cutoff criteria should be. Next slide, please. Because of the vast amount of information that we collected, we were able to identify pre, peri, and postnatal variables that may contribute to hypercikemia, separate and independent of a dystrophinopathy. And so here we show predictors with effect estimates of what most significantly contributes to elevating CK. And not unexpectedly, traumatic deliveries such as those with shoulder dystocia, the use of forceps, vacuum, all significantly elevate the risk of having an elevated CK at birth. Next slide, please. In summary, using a more inclusive criteria for a research basis of 97%, we identified a higher prevalence of female carriers at birth than would otherwise be anticipated based on the generally accepted 1 in 5,000 live male birth prevalence that we see. And very unexpectedly, we did not identify any males in our cohort. And we asked, why is this that we didn't see any males in our center? Is it because the disproportionate use of prenatal genetic screening for mothers that undergo birth at the hospital this was done at? Over 50% of to-be mothers underwent genetic testing, potentially avoiding the birth of males with Duchenne. An answer that we can never find, a question that we can never find the answer to. Was it inadequate assays, or do we just need more study participants? We demonstrate the feasibility of tagging along our protocol to existing structures without the need for additional lab draws. Our cost came out to be about $18 per subject, including genetic test costs distributed over the entire cohort, while identifying certain risk factors as to elevate CK. Next slide, please. And so, as discussed by my colleagues, this research led to more questions than answers. What is the optimal design? Would it be our more expensive but sensitive testing where we do CK followed by genetic testing? Would it be a more cost-efficient CK genetic testing, acknowledging that this may lead to patients to fall through the cracks? What threshold should be used? Should it be the more expensive inclusive 97th percentile or a higher, more stringent testing? Should genetic testing be targeted sequencing of the DMD gene? Should it be a broader neuromuscular panel, or should this be taken in a stepwise approach? And as Dr. Zayman said, is identifying female carriers actionable? Some would argue that genetic counseling can lead to earlier guidance, knowledge, and monitoring for cardiomyopathies, checking family siblings, and guidance for future pregnancies. But is that directly actionable to the patient who's identified to have the disorder? How do we manage those with persistent hypercemia that is not caused by DMD? Is this going to be the other congenital muscular dystrophies, myopathies, limb-girdle muscular dystrophies? Is diagnosis beneficial as to provide anticipatory guidance, or is it more stressful as there is no treatment available? And then, as previously said as well, how do we work with industries to conduct trials in younger patients? Next slide, please. And I'll pass the microphone back to Dr. Batley.
Thank you. Awesome. Thank you for taking us through all of the amazing work that's being done for DMD. That's great to hear. Next slide. All right. And so in addition to the questions just presented, there are several more that kind of go more broadly throughout the country. And so some of those include, how do we ensure that we are providing equitable care, including those who might be in more rural areas who are not close to large academic institutions or neuromuscular care centers. How are we able to reach the underserved? We know that with DMD, for example, the age of diagnosis really hasn't changed in decades, despite, I think increased awareness and understanding of the disorder, and that is particularly pertinent for those who are in non-Caucasian groups. And so how can we ensure that everyone is receiving the same kind of care? And then, of course, it's always super exciting to see after the institution of newborn screening, the outcomes that we're able to present on a state-by-state level, showing the impact that can be made in patients when they're diagnosed earlier. But how can we make this bigger and better? Can we do this on a national level to really show the impact? Right now, super hard to do, but something for the future. And then how do we, again, look at clinical trials for these super young boys who may be diagnosed with, especially with Duchenne muscular dystrophy, in an age where we don't really have an understanding of the optimal timing for treatment and expectations of treating a baby or a toddler with Duchenne. And then, of course, psychosocial support is huge. How can we support families both through this really scary time period of diagnostic uncertainty, where we, have a positive screen and are just waiting? And again, genetic testing has come so far, and what we're able to understand in the time frame in which we're able to get this back is much faster than it used to be. But for a family waiting for these results 2 to 3 weeks even is not fast enough. So how can we help them through that time period? And then for those who do go on to have positive results and are determined to be affected by the condition, how do we then support them during a time period where, they otherwise would not have known their baby looks perfectly healthy? We deal with this a lot, especially in SMA, when we're seeing a week-old baby who's just been sent to us and they have 0 symptoms, and the families are kind of left with that feeling of shock because, how can we be saying this when their baby looks, just perfect and beautiful? So how do we best support them, and where do we find the resources to do this? And then, of course, with the expansion of treatments and, the initiation of trials beyond these 3 conditions that we've just discussed, how do we continue to expand upon our newborn screening efforts in a way that is careful and meaningful, but also allowing, that improvement in care to even diseases that are even rarer than these. So it's a lot to think about, a lot to discuss. I don't think I have any of the perfect answers for any of those questions that I just discussed. If either of my panel mates do, feel free to share. But I think we're at a really exciting time, but still a lot left to be determined for sure. All right, next slide. So again, just to kind of sum things up, we know that in addition to improving standard of care and increasing access at a younger age, we are also looking towards the potential to participate in clinical trials from an earlier age, perhaps in that kind of, we call it pre-symptomatic time period where, we have the diagnosis, but clinically not showing any or many symptoms. And whether that can allow access to clinical trials. But of course, there are still barriers with this. There can be different inclusion-exclusion criteria for each of these trials, which still means that they're not widely accessible and available just to anyone. Sometimes you have to have a specific type of genetic mutation or, be just the right age or just the right motor milestones. It varies depending on the trial. And then, of course, there's difficulties with things like travel. If this trial is only open in a couple of states and you live several hours away, that can be really difficult to participate. And then, of course, that brings up the question of equity. When we know that many families who have fewer resources would not be able to do that. It involves taking time off work, traveling, a lot of socioeconomic stress for families. And so if this is going to be something that we're able to move forward with, how can we ensure that we are supporting families who really need it? And then, of course, taking a look at the impact that newborn screening brings upon these diseases and the patients affected by them is super crucial. And so continuing to improve our research efforts, whether it's through trial registries, individual centers, hopefully coming together and work with other centers, one day maybe a nationwide kind of effort to really prove the impact and, kind of seamlessly improve our standards of care and our guidelines throughout the country. Next slide. All right. And so now we definitely have some frequently asked questions that we hear about on a day-to-day basis in all of our clinics. And so we'll just run through these ones. And then of course, we'll have some time for questions at the end from anyone in the audience who might have any kind of general questions. So of course, we often hear, my baby's flagged on the newborn screen. Does that mean they definitely have the disease? And this, again, like my panelists had talked about, depends on the disease and is more likely for some than others. I would say our kind of positive rate for SMA has been highly accurate, but then of course things like Duchenne testing, depending on how it's done, could pick up a lot of other neuromuscular diseases or carrier states and that kind of thing. And so it doesn't mean for certainty that a child does have the disease, but does require additional testing. And then, of course, what to do if a baby is a carrier, and if anything now, what do we have to do, can also vary on the disease. And so I think the most important thing is establishing the kind of communication and having a site of care to ask these specific questions about your specific child is super important. And then, of course, what does this mean for future pregnancies? Determining how the baby developed this disease. Was it something that was recessively inherited? Is it X-linked? Was it a de novo mutation? Will all tell us how this could impact other children in the family. And then, of course, more information and support. Fortunately, the MDA is a wealth of information and so can provide a lot of good resources for moving forward. Next slide. So overall, this is kind of our summary. We know that early detection really matters for many conditions. Screening is the first step, but we do need to follow that with confirmatory testing, and that this kind of screening can vary from state to state and can determine accuracy and the detection rate. Communication with our families is critical. Oftentimes, like Dr. Zaidman said, it's, you know, us getting directly on the phone with these families to help them understand why they need to come in, so that way we can have that more in-depth conversation. The infrastructure to support these families needs to be built up, and then, you know, hopefully in the future we'll see just, you know, expansion of our treatment options, and then also with that expansion of disorders that we're able to screen for. So that way we're taking care of all of our kids as soon as possible. Next slide. And here is a list of all of the resources